Maggie Cameron, and I am the Director of Development and Communications for the EHE Foundation. Before we get started, I want to just share just a few little housekeeping items. The session is being recorded, so if you find you need to leave before it's over, that's no problem. We will be posting this, I'm hoping, by Monday, so we're going to try to turn this around pretty quickly. We've received some questions from you as you registered, so at the end of the session, we will be addressing those. But in the meantime, during the session, if you think of any questions, there is a Q&A function at the bottom of your screen. The Q&A is where you want to put any questions that you didn't already submit ahead of time. And if you didn't submit anything ahead of time, don't worry, please just put your questions in the Q&A and we will do our best to get to them. If for some reason we can't get to a question, we will try to follow up with you afterwards to answer it offline. I want to remind all participants that the EHE Foundation does not provide medical advice. The information provided here is for your information only, and we encourage you to contact your own healthcare provider for any specific questions about your health. Okay, so it's time to get started. With us, as always, is the the EHE Foundation's Executive Director, Denise Robinson. She's also our Director of Research, so let's welcome Denise.
Thanks, everybody, for joining us today. Welcome to this session of EHE 360 Connect. I have a very big pleasure of introducing today's presenter and a true champion for the EHE community, Dr. Silvia Stacchiotti. Dr. Stacchiotti is one of the most passionate sarcomaologists. I have to practice saying that. It's a term that I think she coined. She's just the most passionate person you'll ever meet. By training, she is a medical oncologist who specializes in the treatment of bone and soft tissue sarcomas with a special focus on ultra-rare tumors, of which EHE is one. She is a renowned clinician scientist and a global leader in the sarcoma community. She practices at the INT in Milan, Italy, a lovely place to go. And Dr. Stacchiotti is a fierce advocate for EHE patients outside of her clinic. She spends countless hours to make effective treatments available for all patients. And as Maggie mentioned, Dr. Stacchiotti is going to go through her presentation. Put your questions in the chat. I'm sorry, not in the chat, in the Q&A box at the bottom of your screen. And then after Dr. Stacchiotti goes through her slides, we'll talk through some of those questions. So please join me in welcoming Silvia Stacchiotti with us today. Thank you.
Thanks very much to Denise and to the EHE Foundation for inviting me today to be here with you, but even more to be so much supportive in all the initiatives that we are running around EHE to try to improve research and care of all patients affected by this disease worldwide, and in trying to present the disease and the challenges that patients and physicians are facing to all those who are in charge for the approval of new treatment and new drug. Without without the EHE Foundation, all of this could not be possible. And I am really saying that from the bottom of my heart. This said, let's try to talk a little bit about the role of Sirolimus in epithelioid hemangioendothelioma. These are my disclosure. Starting from an overview about the drugs, the systemic agents that have been used for treating patients affected by EHE and the data that we have around that. I'm listing here all the drugs for which there are at least 10 or more than 10 patients reported in the literature with EHE treated with a systemic agent. And as you can see from here, we have trametinib, a drug, the only one that has been investigated in a study that is prospective and specifically conducted on a patient affected by EHE. In this study, 41 patients were treated with the drug. Then we have data about other drugs that are more commonly used in oncology for also other kind of cancer. Data about this drug are all retrospective, meaning that the result we have were collected looking into the databases that we have in our institution, trying to understand how the patient who received the drug benefited or not from the drug itself. So if we look to the list, we have trametinib, treatment with anthracyclines, doxorubicin or epirubicin, paclitaxel, pazopanib, and interferon. There is a way to measure how the drug works in a tumor that is called overall response rate. With that, we mean the proportion of patients who experience a tumor shrinkage after thanks to the drug that they received. Usually, we classify a response, a dimensional response, according to criteria that are called RECIST. According to these criteria, a response is seen when there is a decrease in the tumor of around 30% compared to baseline. So overall response rate is the proportion of patients who showed a decrease in their tumor of 30% or more during the treatment compared to the baseline. And as you can see here, the numbers are usually low, meaning that all the drugs that are available so far, have been tested so far, usually do not induce a major reduction in the volume, in the dimension, in the size of the tumor. Here, the drug that apparently gave the better results was paclitaxel, but this is not really different from all the others, and also the number of patients treated with paclitaxel is low, is only 11 patients. Then there is another way to measure the benefit of a drug that is called progression-free survival. Progression-free survival is the interval between the day when the drug is started and the day when the drug is stopped due to the evidence of disease progression or death or other reason for which the disease show to get worse. The median progression-free survival is given considering the time when the 50% of the patient treated with that drug had the progression-free survival. So basically, with the trametinib, we had the median progression-free survival of 8.1 months, meaning that 50% of the patient progressed after 8.1 months. Doxorubicin-based regimen have a median progression-free survival of almost 6 months, paclitaxel less than 3, pazopanib less than 3, and interferon around 9. Again, you can see that the duration, the effect of the drug is not very prolonged across all these agents, and the two performing better were trametinib and interferon, while paclitaxel, that looked to give a better overall response rate, instead showed a disease progression in the vast majority of patients in a very short period of time. Another way to look at the activity of the drug is looking at the progression-free rate, meaning the proportion of patients who are free from progression at a given time point. And here we have numbers showing what is the progression-free rate at 6 months, at 12 months, at 24 months. And as you can see from here, the progression-free rate at 1 year, 12 months, that is the second line, is 30% for the majority of the agents, meaning that the majority of patients showed progression with all this drug at 1 year. Another important point that limits the value of this data is that not all the patients who started these drugs showed evidence of disease progression before starting the treatment. These studies, these data do not clarify if the patient who started treatment before had evidence of disease progression or not. And this is very important in a tumor like EHE that in some patients can remain stable even without the administration of any drug. What is also important to notice is that trametinib and interferon are formally not available for treatment of sarcomas and EHE in particular, while the drug that can be commonly prescribed in sarcoma and EHE are doxorubicin, paclitaxel, and pazopanib. So overall, the activity of this drug is limited, and in the majority of countries around the world, these are the only drugs that can be given to our patients. Then let's go to see the data around sirolimus. Sirolimus is a drug that has been investigated only retrospectively, so not like trametinib in prospective study. In this case, the overall response rate, the proportion of patients who achieved a decrease in the tumor of tumor size of 30% or more, it was only 11%, 10%, so in the same range of the other drugs. But the median progression-free survival is 13 months, meaning that 50% of the patients treated with this drug were free from the evidence of disease progression at 1 year. And similarly, the progression-free rate shows that sirolimus performed better than all the other agents, with 42% of the patients still without evidence of progression at 2 years. And what is also important to notice is that patients treated with the sirolimus in this series had to have evidence of disease progression before starting sirolimus. This is the paper that reports this retrospective series. These are again the results about the changes in tumor sites. You can also see here that the majority of the patients, 75%, showed disease, stable disease following the evidence of disease progression before starting sirolimus, while around 15% of them did not benefit from the drug and had a progressive disease while on sirolimus. This is the progression-free survival curves that shows how many patients are progressing at any time, and these are the same data we mentioned before, with 54% of patients free from progression, so still benefiting from the drug at 1 year. This is also another very important patient that was put together by the EHE patient advocates driven by Denise. With this paper, we wanted to go back directly to patients and ask, according to their own experience, if they felt that sirolimus improved their disease, quality of life, symptoms, and consistently to what we saw in the retrospective study I showed you before, the feedback of the majority of the patients around the world was in favor of the benefit of sirolimus. This paper was presented also at EMA and FDA, and I think is a really very important example of how working together with the patient and physician, we can improve very much the level of evidence available in rare diseases. And this is another graph that is showing you the results of an experiment that was conducted in the lab. In the lab, using a preclinical model, in this case, a mice model that carries the same tumor that was taken out from a patient with an aggressive EHE, are important tool to allow the comparison among the different agents. And if you look at all these curves, you can see that the curves about presenting sirolimus meaning the blue and the light blue ones, are lower than the other, meaning that the tumor after receiving sirolimus compared to doxorubicin stop growing for a prolonged period of time, and also shows that higher doses of sirolimus can improve more the disease control than lower dose. This is a poster that is not yet published in full in a manuscript that was presented at the ASCO and CITOS, in which we look at what happened to patients in the study I presented you before, treated with sirolimus, who interrupted sirolimus for reason other from disease progression. And what we see here is that the median progression-free survival was 3 months. What does it mean? It means that those patients who stopped sirolimus showed disease progression soon after stopping sirolimus. And this is an indirect way to show that the drug has an activity. Why this is so important? Because when a drug cannot shrink the tumor in the majority of the patient, it's much difficult for us to demonstrate that the drug is active compared to when a drug can shrink the tumor. So what we are left is to show that the tumor does not grow. And if we can show that the tumor, when the drug is stopped, starts regrowing, is an indirect way to demonstrate that the drug works. And this is also very important for those patients who could restart sirolimus at the time of disease progression. There was an advantage compared to those who didn't. Advantage in terms of disease stability and also survival. So all these data want to support the notion that sirolimus is an active agent. Of course, we would love to have a drug that can be even more effective than sirolimus and mTOR inhibitor in general. But for now, it looks that compared to other drugs that are available for sarcoma, like doxorubicin, pazopanib, or paclitaxel, sirolimus is for sure superior. And for that reason, we are really working to try to make that drug and this class of compound available to everyone. And with that, I think I am at the end, and I don't know if it was clear enough or not, and I'm fully available for any question.
That was amazing. Thank you. Having seen those slides before in various forms, I always learn something. I never leave talking with you or listening to you and not learning something. So I want to go into questions and answers right now. And Dr. Stacchiotti, we received a number of questions. We invited participants to submit a question for you when they registered. So what we've done is we've gone through, there were many themes that were common. We've also, just so that the audience is aware, if you submitted a question particular to your case or regarding your management, we may have taken some of those details out because we aren't giving medical advice here, particularly to individuals, but we've done some combinations. So I want to give you the questions that were submitted through registration first, and we'll keep going as they come into the chat. And hopefully through these questions, we'll answer some others. So I want to start with, the question is it advisable to start sirolimus when tumors are stable and no growth, and just stay on wait and watch? And what factors help to decide when to stop wait and watch and to start sirolimus?
Okay, so first I have to say that I forgot to mention that sirolimus and all the other drugs I listed before are supposed to be used only in patients who have advanced disease with evidence of disease progression. What does this mean? Advanced disease is a disease that cannot be eradicated with the surgery. It can be locally advanced, for example, a huge lesion in the liver or in another anatomic area, or metastatic with several lesions in different organs or in the same organs. It is very common in EHE to have several lesions in different viscera. Still, EHE can remain stable on their own spontaneously, even in the lack of any systemic treatment in the advanced phase. And this is seen in, I would say, from my experience, more than 50% of the patients. For that reason, to start a systemic treatment that cannot eradicate the disease, but is meant to stabilize the disease when the disease is already stable by itself, is not indicated, because this means giving toxicity to a patient that does not need this toxicity. There is maybe an exception, and this is the worst presentation, the worst case presentation, when the tumor presents with systemic symptoms and serosal effusion and tumor-related pain. We are learning over the last few years that all these features are suggestive for a more aggressive behavior, in which can be advisable not to wait too long before starting a systemic therapy. Otherwise, it's always better to be sure that disease is progressing.
Very good answer. Thank you. I think that will be one of those answers that many people can come back and listen to again and again on the recording. That was very helpful. Is there a limit to how long people can stay on sirolimus? Is there a downside to long-term use of the drug?
I would say that, of course, you need always to have a balance between the benefit and the risk. There are no drugs without risk of side effects or toxicity derived from a chronic use. For example, sirolimus is metabolized at the level of the kidney, and over the years there could be some insult to the kidney depending from the drug. Sirolimus can be responsible for an increase of cholesterol and other aspects that can worsen the activity of the heart. So I cannot say that sirolimus is without side effect. Still, it is generally a well-tolerated drug that can be prolonged for years. And also, I would say if attention is taken into having the correct blood level, the amount of side effects on a regular basis is limited. For patients who do not need a sirolimus, of course, it's good not to take any sirolimus.
Got it. Perfect. Are there foods or supplements to avoid when you're taking sirolimus to not have an effect on metabolism of the drug? Are there any foods that could influence the concentration of sirolimus in the body?
Yes, the answer is yes, and this is not true only for sirolimus, but for all oral mTOR inhibitors. Sirolimus belongs to a class of drugs that is called mTOR inhibitors, and in this class you can have oral drugs and also injectable drugs. So we have sirolimus or, for example, everolimus, who are oral, and we have temsirolimus or nab-sirolimus that are instead injectable. All oral drugs need to be absorbed at the level of the gastrointestinal tract, and this can be interfered by food, beverages, and other drugs. So for sirolimus and also for everolimus, it's very important to be aware that to reach a regular level of the drug in the blood is very much important, and to do so, you need to take the drug always at the same time of the day, in the same condition, meaning fasting or with a low fat food meal, because fat can can change the level of absorption of the drug, and that there are food that can interfere with the absorption of the drug, and also drugs that can do the same. This is a kind of discussion that should be run with the personal medical oncologist, because, for example, the list of the drug that should be avoided is very long. even though there are some more common drugs like statins or like some antibiotics that should be avoided, it's better to avoid them. While among food, there are common food like green tea, not all the other kind of tea, green tea or grapefruit or curcuma that can interfere with the absorption of the drug. This does not mean that a seldom, very small amount of grapefruit is dangerous, but if someone takes on a regular basis this kind of food every day, the absorption of the drug and then the level of the drug in the blood and then the activity and toxicity of the drug can be modified. So it's important to be aware of all of this.
Okay, that's great. You touched on a lot of things. So not just if you're eating, but what you're eating and when you're eating or drinking is really important. And you hit on a question that I was going to also ask you, which was drugs, drug interactions. And you touched on statins, which is important because that is a class of drugs that's being investigated in the lab now for its ability to have effect or to treat EHE. So and that is a commonly prescribed drug, right?
Yeah,
for many patients.
From the technical point of view, all there is a system in our liver that is very important to metabolize food and drugs. And this system is called CYP3A4. This system is used by many drugs. All the drugs that are metabolized by this system are in a list that is very well known to all the medical oncologists and physicians. Statins are one of the drugs in this list, but they are not, of course, the only one. And so you can easily ask your doctor if any of the concomitant medication that you are taking for any reason, hypertension, hypercholesterolemia, and any other thing is forbidden or is maybe better to be changed and so forth. So this is a kind of discussion that at the personal level can be conducted with a treating physician in a very easy way.
Yes, perfect. So for everyone, when you're going to your different physicians, if you're seeing your primary care physician or you're seeing your oncologist, making sure that everyone knows what the different drugs are that you are taking is really important. Yeah.
And also, we are always used to say that there are herbs and other homeopathic treatment that maybe we don't know very well, but can interfere. Like, green tea is taken a lot to clean the body or, for similar reason. I also like it very much. But for example, this is not the best, drink when you take sirolimus. And similarly could happen for many other kind of compounds. So it's always very much important that you confront yourself and you report what are you taking to be sure that anything is wrong.
Excellent. Thank you. Thank you. Here's an important question. Can you explain the targeted therapeutic level of sirolimus when treating a patient versus I'm taking this dose? This is my dose level. Can you explain that and how that's different, and also how that should be assessed in patients? If in a best practice, it may not be the same practice around the world, but kind of from your experience.
Okay. So sirolimus is a drug that has been used for years in other indications outside oncology. For example, in a transplanted patient, among which also EHE patient who receive liver transplantation. And basically, we learn from there. So our colleagues always advise a patient receiving sirolimus to look to check the level of the drug in the blood. And this is very easy. You just need to go to a lab that can test this blood level of sirolimus. Usually big hospital that also have transplanted patient can do that. It is important that the blood is taken before taking the daily dose of sirolimus. Otherwise, you can have a peak that covers, you know, a low level of the drug. This said, learning from their experience, we initially knew that the active level of sirolimus is seen when it is more than 15 nanogram per deciliter. More recently, also looking at the results from the lab, we tend to have 20 nanogram per deciliter. And this is especially true for patients who are presenting with pleural effusion, serosal effusion, and systemic symptoms. What we are observing is that in this patient population, if we go below 20-25, the activity of the drug is usually not seen. We usually try to avoid going above 30 nanogram per deciliter, but for patients with the more regular presentation, 20 is enough, and I don't think there is any reason to try to reach 30. So I would say that in general, around 20 is the right level to keep. For patients with the more aggressive disease, is maybe better to start some more individual conversation and see if the toxicity does not increase too much while increasing a little bit the blood level of the drug.
Great. And also, I want to ask you, if someone has a lot of side effects, let's say that they're, this leans to a question that someone else put in, if they're having a lot of side effects from the drug, and they may be having symptoms also from the disease, so it may be hard to tell the difference. If someone backs down or they discontinue sirolimus and then they want to come slowly build that back up, is it likely that those side effects are going to reoccur, or is it possible that you can come off of the drug or go to a very low dose and then work your way back up and try to get rid of those side effects?
So okay, so first I need to specify, I didn't do that before, that the time needed by sirolimus to reach the constant level in the blood is around 2 weeks. So when you start sirolimus, you need to wait for at least 10 days, possibly 2 weeks before going for the blood level testing. Otherwise, you can down-estimate the level of the drug. Second, when you stop the drug, it takes some days to get rid of the drug. For the same reason, if you stop sirolimus today, the drug is still around at an high level tomorrow and the day after. So when there are side effects and you need to stop the drug before seeing an improvement, you need a few days. This said, when the toxicity is high, and this is usually unexpected, the first thing is to go and look at the blood level of the drug, if possible, because there are patients, even if they are a minority, that with a very low dose, usually we start with a 5 milligram per day of sirolimus, but there are patients who can reach the level, the right level in the blood also with 1 milligram per day, while in other you need maybe 7 or 8 milligram. So when you start with 5 and you experience a very unexpected toxicity, high toxicity, it's very important to look at the blood level and stop the drug. Then, of course, sometimes distinguishing the toxicity of the drug and the side effects of the toxicity of the drug and the symptoms related to the tumor is not easy. And in general, when a patient is benefiting from sirolimus, the symptoms improve. If you have a worsening of everything, there is a problem.
The drug is not doing what it needs to.
Yeah, and then when you stop the drug for toxicity, if it is mild toxicity like mucositis, not necessarily it comes back. If it is a toxicity like ovaric cyst, it is likely that they come back. If it is a toxicity like increase in cholesterol and so forth, they are likely to come back. So depending on the kind of side effects, there are some that may not come back, some other that usually come back. Maybe I didn't answer your question very well, but
that was good. That was a very good answer. I think the thing that I took away a lot from that is that understanding once you stop the drug, what were those symptoms or side effects? Are they symptoms or are they side effects? And then you might be able to understand if it's caused by the drug or it's caused by the disease, and go from there.
I think that in the vast majority of cases, it is not that difficult to distinguish the side effects of the tumor compared to the toxicity of the drug. Usually the drug does not provoke pain, does not provoke fever, does not provoke asthenia, does not provoke dyspnea. These are all related to the disease.
Mm-hmm.
While what we more often see with sirolimus in terms of side effects are mucositis, are alteration of the menstrual period that usually come together with ovaric cyst, as I was saying before. Then there is for sure an increase in some parameter in the blood, like cholesterol, triglycerides. Then sometimes there is a mild decrease in the white blood cell count, and there can be an increased risk of infection, especially during another viral infection. So it is easier for a patient to have a stronger cold or a complication like pneumonia following influenza and so forth due to sirolimus. And this is the reason why we always need to stop sirolimus in case of any kind of infection, and get very close to the general practitioner or to the treating physician to see if there is the need for an antibiotics to protect, to prevent more complicated infection.
Yeah. Yeah, you're touching on another question that I have here from the registrants. So is there a way that you might recommend to your patients to boost immunity while taking sirolimus?
I think that before starting sirolimus, like for all oncologic patients, to be vaccinated against pneumococcus, against COVID, against this more common infection is good. It's difficult to say if receiving this kind of vaccination during treatment with sirolimus can boost the same kind of immune reaction. So usually we suggest patients to stop sirolimus for 2 weeks if there is a plan for vaccination. And I think that this is in the vast majority of patients not harmful at all. Then aside from vaccine, I'm not sure there is anything specifically helpful to boost the immune protection in patients, aside from having a regular life, a regular diet, and so forth.
But thank you. Do you have any thoughts? You mentioned before nab-sirolimus for as an injectable, as an infusion form of the drug. It is a different product. Can you speak to that for EHE? Do you have any thoughts on that?
So from what we know from the mechanism of action of mTOR inhibitors is that there is no reason to believe that the activity of any of the mTOR inhibitor is different in EHE. So even though data are more on oral sirolimus, I have no reason to believe that other drugs like oral everolimus or nab-sirolimus or temsirolimus are less active. The advantage of injectable drugs like Sirolimus is, of course, that there is not that problem of the absorption and interaction with food, beverages, and other oral drugs. So maybe for those patients with a more aggressive variant of the disease that really need to reach quickly a good blood level of the drug and to keep that blood level in the range chronically, an injectable drug could be maybe better. And this is something that we probably see also in other diseases like PEComa. The disadvantage of injectable drug is that, of course, patient has to go to the hospital more often to be injected, while oral sirolimus can be taken at home. But in terms of monitoring the blood level and so forth, there are for sure, in principle, advantages coming from the injectable version of mTOR inhibitors.
Okay, good, thank you. There's a question in the Q&A regarding stopping and then starting. And if you stop the medication and you restarted it, have you experienced that the medication had been effective before and then was not effective? But then I also want to add a little add-on to this. How, if you've just restarted the drug, I'm assuming that you might want to wait a little while to give the drug time to be effective before you scan to see if the drug is effective. Can you speak to that, of that discontinuation of the drug and then restarting the drug? Does it always kind of start back and is as effective as it was before?
Okay, so another thing that is very important for me to underline, and as a researcher I should have said this much earlier, is that all what we are discussing together comes from retrospective data and personal experience. These has many limitations. So we really hope that the observational prospective study we are running, and possibly in the future a prospective formal study, will add more precise information. This said, on average, I have to say that discontinuation of sirolimus that is often needed, especially in those patients who are on drug for prolonged period of time. They can have to undergo another operation, or they can have a pneumonia. I mean, there can be many reasons for a drug discontinuation. Usually, at the time they restart the drug, they benefit from the drug again. This is true, I would say, for the vast majority of the patient. What is more complicated is what is seen again for the small proportion of patients with a more aggressive variant of the disease, in which there can be, during the discontinuation, a worsening of the general condition and the need for a lot of concomitant medication that can interfere with the activity of the drug, and also with the possibility for the patient to take the drug itself. So in general, I would say yes, when you discontinue sirolimus and you restart sirolimus, the drug starts working again. This can be a little bit more critical for patient showing a fusion. And for that reason, in this patient population, I believe that is more advisable not to discontinue the drug for long.
Perfect. That's a good answer.
In terms of scanning a patient, maybe this was your other question. So after how long do we suggest to run a CT scan or an MRI? Usually we do that after 2 months. 2 months is a time good enough to expect no more disease progression if the baseline was taken close to the treatment start. So our suggestion is always to have a baseline radiologic assessment done within 4 weeks from starting sirolimus, and repeating the scans after 2-3 months to be sure that the disease is stable. To see some tumor shrinkage may take longer, but what we really do not want to see in a patient that was progressing before is that the disease is progressing again. Then, when a patient is on treatment for a long period of time, the CT scan MRI can be delayed. So usually after some months, we go to a CT scan every 4 months, and then maybe also every 6 months.
Okay, good. Thank you for calling that out about the timing of the scans. We know from patient-reported information, and there's a question in our Q&A about everolimus and sirolimus, like comparing those. But if a person was on one drug or the other, let's say you were on everolimus and then that became ineffective, or maybe you developed side effects to that drug, is there a thought that you could switch over to sirolimus and start taking that, and you might have different side effects, or it may become more effective? Any thoughts on that or experience?
Honestly, we don't have any comparison that allow us to, to give, I think, a correct answer to that. Every time there is a toxicity or inefficacy, I always suggest to look at the blood level of the drug. I'm sorry that I'm keeping on repeating the same, before changing the drug, to be sure that the drug is taken at the correct dosing. And for example, we have recently started the treatment in a patient, and she was progressing. She received 5 milligram per day. She could not look at the blood level of the drug. She repeated the CT scan. There was a slow progression, limited progression, less than it was before, but was there. And eventually she came, we tested the level of the drug in the blood, and the level of the drug was really below what required. And increasing of 1 milligram per day was not enough. And now we are trying with 2 milligrams. So she's basically now taking 7 milligram per day. So again, before changing, be sure that the drug is taken at the correct dose.
Very good call out. Thank you very much. I think that there's a question regarding discontinuation, like just taking a break. And we talked about discontinuation, but do you ever recommend, or do patients come to you and say, I'd like a drug, I've heard it called a drug holiday. I'd like to give my body a break from a drug. You mentioned earlier, perhaps not with plural EHE, that might not be where, I think I heard you say that might not be one that you would really advise. Yeah.
Then otherwise, it's always a matter of discussion with the patient, because I believe that quality of life matters a lot. So drug holiday can last 2 weeks, a month, a year, or years. Of course, there is a difference. And I think that on average, we have to say that after discontinuing sirolimus, it's not uncommon to see that the drug tends to progress again. This may take a few months. It does not happen the day after. So if there is a request for discontinuing the drug once in a year or twice in a year for 2 weeks, I don't think usually this is a major problem. Mm-hmm. But of course, if it comes 2 weeks every month is different, or 6 months is again different. And if the patient has very limited disease, is different compared to when a patient has a lot of disease. Pleural effusion is an issue, but also, for example, having an extended disease at the level of the liver to avoid liver failure. So there are several conditions in which it's better to avoid treatment interruption, while there are other conditions in which this can be discussed and is doable.
Okay, great. That was helpful.
The disease extent, aggressiveness, Also the time when when sirolimus was started. Usually we try not to have a drug holiday within the first year of treatment, but if a patient is on treatment for, 3 years, and decides that want to stop for a month, I think this can be done.
Yeah, okay, great. I want to dive in a little bit. So the data that you shared, you showed the trametinib data from that study, and now, of course, there have been and are T inhibitors that are in clinical trials. They're in early phase, so these are not in widespread populations of EHE patients yet, but for more aggressive disease. The trametinib study certainly was in more aggressive patients. So we want to make sure that we're talking about similar people. But if people are presenting in that aggressive state and they're having to choose between what treatment would I consider, and you might, people will look at the data on trametinib, and I say people, clinicians and patients, the whole care team, everyone together, Sirolimus and TEAD inhibitors. Do you have any rationale or thoughts as to why to lean one way versus another? How do you choose?
I think that I hope that in 2 or 3 years, we can have a better understanding of the real role of TEAD inhibitors, meaning the activity overall and in the 2 different subsets, less aggressive and more aggressive EHE. So usually when I have a disease like EHE for which there are no formally approved drugs, I tend to offer a clinical study if the study is there. But before having any understanding of the activity of a class of compound, is difficult to make any comparison. So usually we offer what is available at local level. For example, in Europe, we do not have any access to trametinib. So for me, is not enough. For my patient, is not an option. Here we have mTOR inhibitors, we have anti-angiogenics, and this is usually our first choice. But in general, I don't think we have data good enough to make any kind of comparison. So again, the decision has to be taken according to what is available, what kind of presentation the patient has, and also what other concomitant medication or diseases are there, because this also can make a difference.
Mm-hmm.
So my answer is I don't have an answer.
Yeah, and unfortunately, sometimes it really does come down to what is available and not necessarily what is the preferred option. And it varies a lot by region and or parts of the world. So thank you for the advocacy work that you do to help make some of these treatments like Sirolimus available for more people. That's really important. So we're at about 3 minutes till the hour. And I just wanted to just re-scan the chat and or the Q&A. And Maggie, if you have anything else that you think that is really burning in the Q&A that you feel like we haven't gotten to, we'll be glad to hit on those questions. I think that it's important, you pointed out too that no prospective, we don't have long prospective data. And we have very few studies. We have very few studies with very few patients in EHE. So I wanted to just highlight, the work that you all are doing in Italy, the work across Europe with the EURICAN patient registry, and work that the Canadian group have a registry going in Canada. We have a patient registry in the United States. I think just bringing together more patients' experiences from the clinicians, from the medically reported side of experiences, as well as from the patient's reported side, is always important to keep gathering data.
Yeah, it's very, very, very much important. And this is also important for future studies and new drugs, because when it comes to designing a new study, we need to have something to be used as for comparison. So all kind of evidence that we can gather together, we can collect together, is really making the difference here. So it's very, very, very much important.
Let's see, one last question. Maggie's going to give us time here. Common side effects most common side effects, if you had to list the most common side effects that you see from sirolimus in patients.
Yeah, I have to say that, as said before, in the majority of the patients, we do not see side effects. And this is very important because many patients are very young and they, want to run their own activity. They want to go at work. They want to go, to enjoy time and so forth. So sirolimus and mTOR inhibitors as monotherapy are usually very well tolerated. And of course, pregnancy is not a possibility here, and this is for sure a big limitation. But otherwise, the quality of life usually, I would say, is if not very good, is fair. This said, the more common side effects I see when the blood level is kept within the correct range is mucositis. That usually stops with the discontinuation of the drug, but can also be prevented with cleaning well the mouth and also avoiding some kind of food like spicy, and alcohol. I mean alcohol with a high alcoholic level and so forth. Then another thing that is more common that probably described, at least in oncology, is ovary polycystic disease with alteration of the menstrual period. This is very common. It's uncommon to have a big cyst that requires surgery. Even this is not impossible. But alteration of the menstrual period are not that uncommon, and patients should be informed about that. Then, as I said before, there is an increase of cholesterol that sometimes is also very important. And on the long period, this can translate in cardiac problems. So it's very important to monitor the cardiac function together with the ultrasound of the pelvis and to undergo regular visit with the gyno. And there is for sure an increased risk of infection, not as much as when we have neutropenia with chemotherapy, but patient taking sirolimus can be a little bit more fragile, especially when it comes to winter time. There are viral infection around. And I think that these are the more common side effects.
Okay, excellent. Thank you so much.
But then I have to learn from you.
You've answered hundreds of people's questions today. This is amazing, and it will continue to be rewatched, I am certain. Lots of good chatter and hearts going up here. I can see them. Thank you all. Thanks for being here. I don't know. I think, Maggie, I will wrap up, I think. I want to just say an enormous thank you, Dr. Stacchiotti, for being here today. Thank you for being here every day, virtually. You're always here. So thank you all. Thanks for coming. We really appreciate it. Great to see you always.
It's my honor to be here, and thanks for the support.
Thank you.
We need to work together to succeed.
It's always awesome. Thank you. Be well. Be well, everyone. Thank you for coming.